Good morning. Thank you all for joining the Plan Mecca Digital Mastery courses. My name is Jody Rodney, and I'm the Vice President of Marketing and Education for Plan Mecca USA. I would like to introduce today he plays one on TV though, Chad WOOTERS from Making to Sleep, and today's topic is Introduction to OSA and Dental Sleep Medicine. Before we get started, a few things. Obviously all attendees are muted. You're not on camera, so hopefully everybody has your coffee, tea, what have you. Enjoy yourselves, and hopefully you will get a lot of great takeaways today. Just a few notes: we will hold all questions until the end, and at that time we will open them up to Chad WOOTERS. Please make sure that all of your questions are submitted via the Q&A area and not via the chat. It helps us kind of control how we answer them and dismiss them, so that it helps us go through them easier. Additionally, we will be recording this survey, or this mess today on my words. We're recording this webinar. We will include the link to the webinar in our post-webinar email, as well as the CE survey link. So I will post the CE survey link at the end, right at the beginning of Q&A. So hang on to your hats and let's get started. Take it away, Chad.
Thanks, Jody. Hey, good morning, everyone. We're going to get started. First, rules and some disclaimers. One, obviously, I'm part of the Plan Mecca team, not as a staff perspective, but I'm one of their KOLs. And secondly, we're going to go through an introduction to sleep medicine today. And one of the rules for this content in particular, anytime you're learning about sleep, is that you're not allowed to fall asleep. That's like the only rule in sleep medicine courses. You're not allowed to fall asleep. If you do, then hit up Plan Mecca. They've got home sleep studies for you. But all seriousness, let's pay attention today. There's going to be a lot of content we're going to go through, and we're going to really focus on a 10,000-foot view of what sleep apnea is, and then really get to hit on what it means for you as a dentist or a dental clinician. How do you, as a dental clinician or a dental team member, come in and actually do this in your practice? We're going to talk about that scope of practice, and at the end of the day, we're going to give you some action steps that you're going to be able to take home over the next couple of days and come back with our week. The other thing is we're going to ask for some involvement here. So it's a little early here in California where I'm from, and I'm sure it's kind of early where you are, wherever you are in the US or the world. And I'm going to be asking some questions like, where are you from? Or if you are here, then put your hand up. There's a button on your Zoom meeting thingamabobber, and that button says raise hand. There's going to be a couple questions. I need you to participate. So if I ask a question like that, so if you understand, let's see, raise your hand. I can see you guys. Thank you, Sharon. You rock. Sharon is apparently the only one. Oh, there we go. I was going to say, a couple of you guys aren't listening to rule number 1. That's don't fall asleep during a sleep course. Thank you, Katie, Amanda, Shannon. You guys rock. Victoria, I'm seeing a pattern. Oh, nope, there's Philip. Okay, I was like, so far it's mostly women. Okay, cool. Thank you. All right. Let's get started. First, some of you guys have been on our previous webinars, but some of you haven't. So I'm going to give you a little bit of introduction to myself, just from a background standpoint. I come from the world of business development and sleep medicine and dentistry. So for me, worked in business development for a couple of years, and then actually got transferred into dentistry. I worked there for some time. It was an amazing experience. Got to learn a lot. It was a really big culture shift. I wasn't that dental business got to run this way, and actually working in a practice taught me a significant amount. Then I met Michael Cohen, the CEO and founder of this company, and kind of became his right hand here in Awaken to Sleep. And I've been here for, oh my gosh, it's been a few years now. So it's been really fun being here. That's my professional background. I love business, I love dentistry, and I love sleep. So not just sleeping in my bed, teaching about sleep, doing all this stuff. I'm a bit of a cowboy, so I'm from Southern California, so most people don't believe me. But you can't see them, but I'm wearing cowboy boots. It's a real thing. This is a horse named Galaxy. He was a horse at a ranch for children of the incarcerated that I serve at occasionally. I'm a man of faith, love God, very involved in my church community out here, and student of life. So as much as I get to teach you guys, I find that through your questions, through your engagement, through the things that you can add or share on Facebook, whatever it is, I end up learning so much from the people I get to work with. So thank you in advance for the things that I'm going to probably learn from you today. A little bit about my why. Now, I apologize for some of the outdated pictures. I'm one of those terrible picture takers. But on the left and right, my niece and nephew. On the left, my niece is the most adorable thing that ever existed, and I will thank you for that title, no questions. On the right-hand side are my little brothers. Now, they're a little bit older than this now, a couple years actually, but they are two of the reasons I show up. I love getting to be an example to them and come to work and get to do this, talk to hundreds of people on a Friday morning and help people change lives. So they're part of that reason. In the middle is my fiance. We're getting married in August 1st. What? That's right. It's going to be a good time, assuming that we can actually, have a wedding. If we can have a wedding, it's going to be a blast. And as you can tell, obviously, from the picture there and the picture here, I'm stepping up in the world as she is far out of my league. So she is amazing and just getting to provide for us and all that is awesome. Also, kind of fun fact, as of recently, I got to pull a fiance card and actually, thank you, Rava, pulled the fiance card and required that she do a home sleep test. And she was diagnosed, as I suspected, I guess 2 years ago or something now, but was a mild apneic individual. So we are an apneic family, me and her. And here's my story and why this topic matters to me, and also why I'm going to be teaching next week on our screening topic. But I was someone that was always tired. I'm a busy guy. I like to volunteer. I like to do a lot of fun stuff. I like to exercise. I like to hang out with my little siblings and my nephews and niece, and I was just tired. This one time led to a terrifying moment where I had to go help a friend in need. It was like 11 or 12, and I had done some volunteer stuff all day. I was just going all day long, pulled up to his house, dropped off a gas can so he could fill up his car and do something he needed to do, and fell asleep in his driveway. I woke up in my bed. Now I had no substance, no alcohol, nothing like that, just had little less sleep. And I fell asleep in my car in his driveway, and I woke up in my bed. That night, I had a dream. That dream was that I was driving on the freeway, and I was headed straight for the center divider. Luckily, in my dream, I had enough cognition to turn the wheel, stay in my lane, at least mostly, and then a couple hours later, I woke up in my bed, and I was like, oh, that's weird. I texted my friend. I said, hey, Tyler, thank you for giving me a ride home. I don't even remember getting out of the car, moving to the passenger seat or, whatever. And he said, Chad, you saw when I got back. I slept, drove, and I almost crashed into the center divider for real. So for me, that was the day I started taking my sleep more seriously. And a couple of years later, when I started hearing about dental sleep medicine and actually started learning about it as an administrator in our dental practice, I started to look into it and say, okay, well, why shouldn't I get tested? I'm always sick. Maybe this is me. And my sister, she used to work here, and she was like, Chad, you should probably check this out. This is really interesting stuff. And the dental professionals I worked at literally were like, Chad, look at you. You're $135. You're 5'10". Like, you don't have apnea. Get a snore guard. That won't snore anymore, and you'll be totally fine. Well, the reality is that after working with this company and onboarding protocol being that I have to do a test, actually we have to do all of the tests that we own, which is a lot. So you do a lot of home sleep studies here. But I actually came out diagnosed as a moderate apneic. I used to have 21 times events per hour. We'll talk about what that means in just a moment here, but me. Now I've gained a couple pounds in the last couple of years, but the reality is 21.7 times. As a moderate apneic, I would have lost 7 to 10 years of my life statistically. And if I had never left that dental practice, then I would have made my apnea worse. I wouldn't have snored. With a snore guard as an apneic, I would have become a silent apneic and gotten undiagnosed for even longer. So this is really important to me. Additionally, I was actually treated with an oral appliance for about 8 months before I pursued surgery and got my tonsils cut out. If you're ever looking for an exorbitantly painful surgery, I highly recommend tonsillectomy. Fantastic. Real quick, can you guys all hear audio? Are we good? If audio is an issue, thank you, Anna, for bringing that up. May want to refresh the page. A couple raised hands. Thank you. Okay, I'm dialed in on my phone, so check your internet connections real quick and see if there's if that helps, and if there's still an issue, let us know. Okay, we're going to keep going because we do have some slides to get through. Yeah, just refresh your broadband. I want to make sure if you guys want to reduce your broadband, you can also actually call in via phone call and not be using your audio. That'll help. That should help make it consistent. So we're going to go here. Before we get started with our content, guys, we're just going to ask this question of why are you here today? You know, as a dental clinician, as a dental provider, there's money to be made. I don't want you guys to think that this is just going to be about purpose and whys and meaning and all that jazz. It's going to be a little bit about that. But there's money to be made here. But for you as an individual, what is the reason you're here? I'm sure part of that reason is to go bring this service to your practice and help more people. I'm sure part of that is maybe you have someone in your life who's struggling, or maybe this is something that your team is asking you to do. But understand why you're here today and take this education with a grain of salt. Remember, there's no falling asleep in a sleep course. So let's jump in with sleep apnea, the glimpse. The first thing that we're going to look at is definitions. Now, we've got, how can we start this presentation with the most exciting thing possible? Give them a bunch of words on a screen. No, these are important for sleep and sleep apnea in particular, because we need to understand what apnea is, its clinical definitions, and how do we categorize the elements that are used for diagnosing. So the first definition you got to know is an apnea. An apnea is when we stop breathing, or when there's a reduction of airflow of 90% for 10 seconds or longer. We're going to demonstrate why this 10 seconds or longer is important in just a little while here. Second definition is hypopnea. It's a reduction in airflow for 30% for 10 seconds or longer with associated 4% drop in blood oxygen. When I talk to patients, I say this is when we almost stop breathing, and it causes our oxygen in our blood to decrease. Our sleep score, or AHI, is one of the typical measurements that we're going to see when patients come to us. But this is what we take the number of apneas and hypopneas and we average it out per hour, our apnea-hypopnea index, or an index is all the events that we had while we slept. This is one of the major diagnostic components in understanding sleep apnea because it's going to give us that sleep score. The respiratory disturbance index is an AHI plus the total number of RERAs. RERAs are considered respiratory effort-related arousals. Say it again for you. Respiratory effort-related arousals. Now, we're not talking about the good kind of arousals here. We're just talking about waking up because we're having a hard time breathing, or there's extra effort that's having to be exerted. Maybe it could be snoring or upper airway resistance syndrome. Any number of things could cause a RERA. But the point of a RERA, while we measure this in the RDI, is because we're waking up. There's two major components to sleep. There's how long we sleep and the quality of sleep that we get. If we're waking up for any reason, then we're interrupting our sleep cycle. Now, that gets worse and impacts our health even more, which we'll talk about in just a moment here, when our heart starts to work harder because we're having cardiac events and oxygen deprivation. So we're going to talk about the effects that has on our body in just a moment here, but our sleep score and our diagnosis can be based on either or our AHI and or our RDI. So just understand those are the two measurements to determine a diagnosis. All right. So some of you guys, like Todd, for example, who submitted a question that's more of a comment, we are going to go over some of these basics. And these basics are important to know. And we're going to try and give you some patient-friendly ways of communicating that. So normal, healthy breathing is done through the nose when we sleep, I should say, when we sleep. And basically what we're going to make sure we're doing is getting just air to our lungs. We can see in this picture that we have a patent airway that is open, that air is passing through. We got mostly nasal breathing and some oral breathing. The air is being cleaned and moistened through our nostril. This is a great case. Okay. Now, some of you guys are probably nerding out because you know that if you put this patient upright and you put a little cone beam around the head, you can see a similar picture, at least from a cone beam perspective. We'll talk a little about that. Probably you guys might have some questions as well. So we'll wait on that topic. But this is a cool illustration of what that looks like. Snoring, by definition, is actually a partial collapse. So when we see snoring, it's actually because most often the pharyngeal tissue in the back of the throat is vibrating. So when I was a kid, we used to take these blades of glass. This is before video games. This will blow most kids' minds nowadays, I found out, because sorry, side story. I was talking to my little brothers who are in high school now, and they're like, yeah, well, when you were a kid, you didn't have video games. And I'm like, yeah, we knew to have fun, like outside, you know, that place where animals live, right? So here, we used to go outside. We used to take these blades of grass, put them to our lips and blow. And we used to do that. The blades of grass would create a humming noise. That humming noise is the same kind of mechanism that's working in the back of our throat. the pharyngeal tissue is vibrating and hitting each other, which is causing a vibrating noise to come out of our mouth and or our nose. Now, there is some snoring that's caused up in the upper airway. That wouldn't be caused by the pharyngeal tissue and is not always treatable with an oral appliance, but that's a whole other topic. So here, most snoring is caused by a partial collapse in the back of the airway where the pharyngeal tissue is vibrating. So kind of fun fact, if your patients need a demonstration, grab a piece of paper, fold it in half, do the same thing that you do with that blade of grass from when you were kids. So snoring, again, is by definition a partial collapse. Obstructive sleep apnea is a full collapse or multiple full collapses and multiple partial collapses. What we see here, and the biggest difference in these last three pictures is we can see the various soft tissue structures or skeletal muscles are actually expanding. This is because our body falls into a state of atonia, which is when our skeletal muscles go to sleep. When our skeletal muscles go to sleep, everything expands. Our tongue expands, our tonsils expand, our throat expands, and gets narrower. For patients that have too much small tissue and that basically the wrong anatomy or the wrong, you guys know the skeletal structure, the soft tissue structures, all of that. If there's not enough definition in the mouth to allow air to pass through, then it's going to close. And when our body wakes up, it's going to tell the body to wake up. The skeletal muscle is going to gain tension and muscle tone. They're going to decrease in size. We'll often see the jaw go forward and up. We'll see the tongue be pushed forward. Everything is going forward march. We're waking up. We're getting muscle tone, and we're allowing air to pass through. So our body would go from a picture like this to maybe the picture that we saw first with an open airway, but only as a result of our body physically waking up, releasing adrenaline to the heart, and the brain telling everything to just get up because we're choking. So what we can see by these pictures is kind of a clear understanding of the physical obstruction that's occurring with sleep. This is, in case you didn't know already, this is the general step that we have to talk to patients about. And here's the deal. We can't always show patients this information while they're awake and upright. Believe it or not, and it's probably going to blow your mind, but you can't have sleep apnea unless you're asleep. Crazy, right? So when we take cone beams and stuff, that's an amazing image, because if we see a cone beam and we see that patient's airway is highly constricted in that image and they're awake and upright, then we know that may be the best airway they're going to have. So it's kind of crazy to consider these things as we look at that, because, and your technology in your office is going to play a big role in that. But just understand that this is the general mechanism by which apneas typically occur. So real quick, hands up, who's ever had in and outs? I just need to know who my people are. I'm just kidding. We're from California. I mean, do your hands up. I want to see those people. Thanks, Philip, Nina. Kay, sorry, I probably just butchered your name. We at California kind of have like the plug on in and out. Now we know Texas and Arizona and a couple other states. You guys can also claim that you have in and out, but like we've got like 4 in and outs within 15 minutes of my house. It's a little ridiculous, I'll be honest. But it's awesome because in and out is kind of a staple here. Now, their shakes, the reason we talk about their shakes is because when you get an in and out shake, it's not like they poured a bunch of milk into a thing and you've got this slush. It is a real ice cream shake. Like you can put a spoon in it, take it out, and the whole shake's going to come with, right? So how does this apply to sleep apnea? Well, Bernoulli's principle is in the law of fluid and aerodynamics, or a law of fluid and aerodynamics. And it also helps us understand how planes fly. As related to this milkshake, when you get that milkshake and it's fresh and you go out there and you suck on that straw, you're going to see that nothing happens. So the straw collapses because there's a reduction in pressure in the straw because the end of the straw is stuck with ice cream. The straw collapses, and what do we do? Well, there's 2 things we can do. 1, we can stop sucking, novel concept. And 2, we could flip the straw over and pinch open the end of the straw and suck through that end. And now, if the ice cream is soft enough, it'll actually come through. So how does this relate to the airway? Well, flip that milkshake upside down. And be careful to do that. Make sure it's fresh so it doesn't end up on your lap. But we flip that milkshake upside down, and we start to see that that's actually a picture of our lungs and the top of our throat. See, most apneas occur here in the posterior hyperpharynx. And this point is where we're going to kind of equate to the end of the bottom of the milkshake with the solid ice cream. Our lungs are our mouth sucking on the straw that is our throat. When the bottom of the throat is clogged, the straw of the throat is going to collapse because there's negative pressure. So our body has 2 choices. It can, 1, stop breathing. What happens if we stop breathing? if our lungs just kind of take a break, we die. So that's something our body avoids because it knows that inherently. The second thing our body can do is open the airway. It can do this by pinching the end of the straw, which is where we see a lot of our clenching and grinding. Our muscles pull open we can see our bodies telling our mouth to go forward, our tongue's going forward, our body's going to wake up or sit up or take a grasp. So I hope, and this may have ruined your milkshake for you, and I somewhat sort of apologize. You can join the club, but I hope when you see a milkshake, you think of apnea, because it'll definitely keep it fresh in your mind. But what I want to do is show you more than a milkshake. So what we're going to show you is a story of a gentleman who's actually on YouTube. His name is Nick. And this is one of his videos. If you ever want to check out an amazing story, go check out his videos on YouTube. He's actually he's done through a comprehensive treatment plan. And I don't know all the details, but he's cured and he's lost a bunch of weight and he's looking good and feeling good. And this is a story before he was diagnosed with apnea. This is probably a video that some of you have of your significant others or your patients have of their significant others of saying, hey, I know you don't believe me, but you snore and you also stop breathing. So check this out. And as we get started with this video, I want you to ask this question. Is he breathing when we start the video? And what does it look like when he breathes if he isn't breathing? And how long is he not breathing when we stop the video? So let's get started. Let's meet Nick. Right away, we notice that Nick is, we see, it looks like he's breathing. His jaw is moving up and down. And now for the first time, we actually see that he is taking a breath. He moves, his arms are flailing, he's breathing now. And if you get out your stopwatch, let me get mine out. He's a little past 10 seconds now. We're just going to check out. We're going to finish the video up as soon as he takes his next breath. 20 seconds. All right. Looks like about 25 seconds there. Nick didn't breathe for 25 seconds. So my question to you is, who can hold their breath for 25 seconds? If you think you can hold your breath for 25 seconds, go and raise your hand for me so I can see that. If you were to jump into a pool, take a breath, who could do that? Okay, cool. So we're not impressed by Nick. I totally get you. We're going to come back to this in just a second here. But we have to understand, as it relates to air, everyone understands that airway is the most critical part of our life. Obviously, we need food and water. I'm not devaluing that. Obviously, I drink water. It usually has a brown tinge and tastes like coffee, but there's water in that. At least I keep telling myself that, right? So these are important things that we consume and take part of, but oxygen is the only one that we can go less than a couple minutes without dying. Now, why does 10 seconds matter in apnea? Well, I want to demonstrate this and then I'm going to explain it. So real quick, make sure you're putting your hands down. There's a button. I don't remember how to do that. So go ahead and put your hands down. We're going to do this real quick, and we need all hands down to start this breathing activity. As a disclaimer, if you are someone who is pregnant or has heart conditions or has any medical condition that you should not participate in an exercise that you have to hold your breath, please excuse yourself from this exercise, okay? Very important disclaimer. We don't need any calls because something happened because you held your breath, but this is a holding your breath exercise. So please, if you are someone who can't participate, excuse yourself. We're not going to judge you. Here's how this is going to work. We're going to do a guided breathing exercise. So you're going to follow me. We're going to breathe in. We're going to breathe out a couple times. I need you guys to follow my instructions the second I say them, the speed of instruction. First and foremost, please sit up in your chair. If you're standing like me, stand up, relax your shoulders a little bit. And again, if you can't participate, please do not. And here's the deal. I'm going to put a timer on. We're going to have a competition. And bragging rights, because you can say out of a couple hundred people you won or you got close to winning. I'm going to put on this timer. My timer is now ready. What we're going to do, if you make it past 15 seconds, I need you to raise your hands. And then when you get out, put your hand down. We're going to see who can do this. Now, there's 247 people on this webinar, and I've only seen at most 45 hands go up. I can see you. So we haven't started yet. Put your hands down. What are you doing? Come on. These are called instructions. We use our ears to listen. Okay, all right. Let's get started. So we're going to breathe in, big breath in. Breath out, all the way up. Push all your air out. Okay, big breath in. All the way out, push all your air out. And when all your air is out, hold your breath. And go. If you make it past 15 seconds, please put your hand up. We're at 5 seconds. 10 seconds. 15 seconds. You can put your hands up if you're still in. All right, we got, oh, yes, this is called participation, people. Thank you. We're at 25 seconds. Put your hands down if you're out. Oh, we just lost about a quarter of you. We're at 35 seconds. We're down past half. Don't be cheating. If you're out, you're out. Put your hand down. We're down to our final 25, 20, 20. We're at 45 seconds, 15. I know you're fighting. Come on. The champion of the Plan Mecca webinar, 10, 9. We're at 55. Wow, you guys are solid. Look at you go. I think you cheated. I'll be honest. Okay, we got 9 people left. We're at 1 minute and 5 seconds. All right, we're going to crown you 9 the winner here. Here's the deal. Oh, we got 8 left. Okay, Diane, AJ, Sharon, Todd, Darden, Michael, Jacqueline, oh my, Dr. Saheen, I'm gonna guess. Okay, I hope I didn't butcher that name too hard. But what we're gonna do here, and here's why it matters. Who thinks they can normally hold their breath for longer than what you just did? Go and put your hand back up real quick. The reality is that when apnea occurs, now if you did this right, and unfortunately I kind of ruined the surprise a little bit, but if we did this right, what's going to happen is you would have blown all of your air out entirely and then held your breath. I have 10 or 15 people that think they can hold their breath longer. And here's why. Because when we get pushed into a pool, when we get in a situation where we are going to lose our air, our body naturally responds with we take a big breath. Apnea, unfortunately, doesn't work like that. Apnea occurs at a point in the sleep cycle called peak critical. Peak critical is the point of exhalation. Our body is unprepared to hold our breath, and our body has just exhaled all the carbon dioxide and air in our lungs. So when 10 seconds matters, because if we looked at 10 seconds, a lot of you guys probably raised your hand. I didn't even have anyone raise their hand if they didn't make it past 10 seconds, right? But here, when we look at that, you understand that conscious, awake, physically fighting the urge to take a breath. I'm sure the couple of you, the 9 of you that made it past 50 some odd seconds, you guys were like, red in the face, like, oh my goodness, like, I hope I don't have a heart condition, like that kind of, like, it was hard. You were just in it to win it. And I got to say, congratulations, you 9. I only make it like 30 seconds anytime I do that, and probably not even that long. But peak critical happens. We're not prepared for that, and our body is unconscious. Our body senses oxygen deprivation, and that's why 10 seconds matters so much, because we exhaled all of our oxygen, all of our air, and we're now can't breathe back in because there's a collapse in our airway. So if a patient doesn't believe that 10 seconds is good enough and they don't have any pre-existing medical conditions that stop them from participating, feel free to take them through this breathing exercise. And again, they're going to be able to probably hold their breath longer than 10 seconds, but they're awake. They're able to physically fight it, and they'll notice that it's uncomfortable, just like some of you did. So thank you guys so much for participating. That was amazing. I'm so glad to verify that at least 1/3 of you are awake. Okay, so when we talk about severity levels, and we're going to, after we get to the impact and the health considerations, we're going to really start considering what it means in your dental scope of practice and really talk about the workflow and the clinical flow of sleep medicine and where dentists can be involved. So here, if someone stops breathing or almost stops breathing, or has an AHI or RDI of less than 5, then we see that they're considered normal. That person may have primary snoring and can be treated with a snore guard. A person who is mild to moderate, so mild is 5 to 14.9, and moderate is 15 to 29.9 events per hour. That's AHI or RDI, apnea, hypopnea, or RERAs, an average of 5 to 29.9 events. RER stands for respiratory effort-related arousal. Respiratory effort-related arousal. So basically when we're waking up from any number of types of events, there's qualifying events all over the place, but there's quite a list. So mild to moderate patients, we want to focus on those. So you stop breathing 5 to 29.9 times an hour. Those patients specifically, based on the Academy of Sleep Medicine's guidelines, can elect with a physician's recommendation to do oral appliance therapy as a first-line mode of treatment. Oral appliance therapy can be a dual primary recommendation for mild to moderate patients, along with CPAP. Say it one more time for you. Mild to moderate patients can have a dual primary recommendation of CPAP and or oral appliance as a first-line mode of treatment based on the Academy of Sleep Medicine's guidelines and by the FDA's guidelines on approval for oral appliances and mandibular advancement devices. Severe patients have more than 30 events per hour. Now, keep in mind, guys, severe patients are severe. They stop breathing at least 30 times, stop breathing or almost stop breathing, at least 30 times an hour for 10 seconds or longer. They're waking up all throughout their night, 10 seconds at least. That doesn't mean that's all, 10 seconds at least. We just saw with Nick, he held his breath for 30 some odd seconds in an apneic state. So when we look at that, that's a significant amount of their night. Those patients' first line of treatment should be CPAP. Now, we're not going to talk about this too much today, but CPAP is 100% effective if worn. So do us a favor, do yourself a favor. If you have someone that is a severely apneic, make sure they really attempt CPAP. If they're intolerant to CPAP, then at that point, they could also pursue oral appliance therapy as a secondary option. So mild, moderate, severe, those are your guidelines. Those are the criteria that we can treat them with. We're going to talk more about treatment options a little bit later and just touch on that again. We don't have time to get through all those details, but just understand those are the base level guidelines for those severities. So we now understand what apnea is. We understand what it looks like. We may understand what it feels like a little bit. But what we're going to do here is we're going to start talking about how apnea relates to our other health concerns. And this is going to come into our screening conversation next week, and it's really going to play a role in how we view our patients. Now, this first study I want to show you was done by RESMED in 2011, and it asked the question, of those patients who have apnea, how many also have these other comorbidities? So we're not talking about causal relationship here. We're just talking about the fact that these conditions exist at the same time in these ratios. So I want to draw your attention to 4 big ones. Number 1, all hypertension. 37% of patients with high blood pressure also had obstructive sleep apnea. Type 2 diabetes. 72% of those with type 2 diabetes also had obstructive sleep apnea. 77% of patients with obesity also had obstructive sleep apnea. And 83% of patients who took 2 or more medications for their high blood pressure also had obstructive sleep apnea. Now, raise your hand real quick if you just thought of 5 to 10 people in your practice or in your personal life who suddenly sound like they might have apnea based on this slide. Cool, yes, thank you. We got 10 of you, or 20 of you, awesome, thank you. So here's the deal, guys. We have a pandemic on our hands. Now, this study does not show causation, okay? Just want to be clear on that. But let me ask you a couple questions. I'm just going to pose these questions. I don't have the answers, and medical science is currently doing the research to catch up with these questions as well. But obesity, type 2 diabetes, are we gaining weight and having a hard time managing the sugars in our bodies because our body doesn't know how to process them because of the hormones released during apneic events that actually store carbs as fat? It's a great question. Is our heart tired and are our veins worn out? Do we have high blood pressure because we have 25 cardiac events an hour because of oxygen deprivation? Not prepared to answer that question in this webinar. You guys can do your own research on that. Reference Why We Sleep by, oh my goodness, Matthew Walker. That's his name. Why We Sleep, Matthew Walker, Sleepless in America. Amazing content. We'll even reference some of that a little bit later today. So we can understand right off the bat, we have a huge need here. But what does that need actually translate to in America? Now, we may have some international people on the call, so welcome. Thank you for taking the time out. But in America specifically, a couple of years ago, we saw that about 30 million Americans were undiagnosed. 30 million Americans are suffering from obstructive sleep apnea. 10% of those people were diagnosed, and 1/4 of that 10%, 2.5% of the overall population were treated. That's a pandemic. That is something that is going on. That is something that we need to get involved in. You as a dentist, and we'll talk about this in more detail later, but you as a dentist have the unique opportunity to introduce this topic to your patients. Now, what does it mean to be successfully treated based on this study in the AASM? Successfully treated by these guidelines are wearing a CPAP 5 nights a week, 4 hours a night. Who has ever gotten 20 hours of good sleep and felt like $1 million? Go ahead and raise your hands. Okay, didn't see any changes there? Just checking. Okay. Oh, no. Okay, you guys, thank you for participating, but that's not one I expected to raise hands to. Thank you, though. I've never gotten 20 hours of sleep in 4 days, let alone 7 days, and felt like $1 million. And the reality here is that that's what these standards are. So I'm not saying that those standards are not appropriate. I understand CPAP is a very difficult thing to be compliant with, but that compliance standard has resulted in a 2.5% treated ratio. That's quite incredible. Now, again, that's over time. But just if you look at the 27 million people that need your help, if every dentist in America got on board with this and started screening patients together, you would all have hundreds, if not thousands of patients to go around. There's no shortage of need here in the US for you guys to be involved. When we look at what this is doing to our country, again, focusing here on the US, but on the left-hand side, we have the graph of the prevalence of sleep deprivation over 14 days across the US based on state. In adults, it doesn't say the age group on this particular graphic here. But on the right-hand side, we have a graphic that is the level of diagnosed diabetes in adults over the age of 20. Now, real quick, if you can see your area, go ahead and raise your hand. I want to see who's paying attention this morning. If you can see your area on this graph, let me know. But I also, oh yeah, shoot, there we go. You're awake, thank you. When we look at this, we have about 45 people who just absolutely said, yes, that's our group up there. But when we look at the graph on the left, do you guys see a correlation? Now, this is an indirect correlation, but we start to ask the question, are these things related? In more than just if a stars align kind of way. Heart disease death rates, again, if you can see your county, feel free to raise your hand, but we can see here that these graphs are looking remarkably similar. And one more for you is our stroke and death rates. Again, is it coincidental that these areas also reported higher rates of sleep deprivation? I find that hard to believe, and when you do your research into this topic, you'll probably be on my boat. Again, check out the book, Why We Sleep. And then we look at this last stat here, obesity trends among the US and adults, and we start to see here that this topic of sleep, and really just as people grow older and their sleep conditions are worsening, is it really, don't get me wrong, we've got a fast food crisis here in America. I'm not debating that, okay? It's so easy to order DoorDash. I did it last night, right? But here, when we look at this, we can see, is it because people are getting tired more? They're not sleeping more? Their body's not processing chemicals appropriately, and this is compounding over time? Or is it just McDonald's? Or, sorry, other fast food, not just like McDonald's in particular, but you guys know what I mean. So, real quick, give you guys a break from my voice and share with you a little bit more from what some other doctors have to say. Here's a little clip from that video I mentioned earlier, National Geographic Sleepless in America.
May promote disorders such as Alzheimer's disease.
If you don't get the restorative sleep that you need, cancer is going to grow so much faster.
Increased risk for depression, anxiety disorders, substance use disorder.
When sleep gets shorter than 7 hours a night, you tend to see escalation in obesity, diabetes, cardiovascular disease, and death.
I've decided that I now need to get dramatic background for my headphones and for your viewing pleasure, just so we can have like some extra dramatic, like I've got a scary voice, I've been told, but like if you can have like a cool tone behind me, I think that'd be a blast. Okay, so complications of sleep apnea. I recommend right now you take a picture. Take a picture of this slide, print it out in 1080 resolution in your office, and if you pick any two of these things, your patient has greater likelihood of 50 to 60% that they have a sleep condition. Most of these are amazing conversation starters. I'm going to let you figure out that the left-hand corner is probably not a great place to start a conversation. And if you don't trust me, then you go ahead and figure that out on your own and you let me know how it goes. But the rest of these are amazing conversation starters. They are things that are impacting people's everyday lives that they're tired of. Who likes to take 3, 4, 5, 6 medications for their sleep apnea, or is tired of managing their type 2 diabetes, or is tired of being tired. Being tired isn't normal. And that is what's wrong with our current dichotomy in our country. We have to stop accepting tired as normal. It's not okay to be tired. It's not normal to snore. Those two things alone are undervalued as it relates to how it impacts our lives. We shouldn't be tired when we wake up out of bed. If you're tired when you wake up out of bed, then get a sleep test, please. Or find out what's going on, because that's not how your body's supposed to work. So the question we want to ask right now is, who do you know? Real quick, we're going to go through a couple more slides on the social impact. It's not just impacting their health, it's impacting their marriages and their lives. Part of this is the fact that it's sound. Now, real quick, if you are someone who sleeps next to someone who has a, who snores, we'll just say it like that. Who sleeps next to a snorer? How loud do you think the average snore is? Wow, yeah, there's a lot of you. Okay. How loud do you think the average snore is? Between 60 and 90 decibels, depending on the study that you're looking at. Now, some will say 70, 90, some will say 60 to 80. So we're going to say 60 to 90 decibels. So somewhere between a vacuum cleaner and an alarm clock on average. Now, if I slept next to a vacuum cleaner in my ear, I'd probably be frustrated. If I slept next to an alarm clock that woke me up every couple times an hour, I'd probably be frustrated. So if you know someone who sleeps next to a snorer, or if you are a snorer, please understand that that's probably kind of sucky. But we understand that snoring is one of the indicators that they may have an airway disorder. And if it's just snoring, fantastic. That's great. It's a cosmetic condition, and you can get a snore guard to help with that. But if it's not, if it's really a bigger condition, well, then that's life-changing. So pretty big deal here. And now we now know that question, the answer to the question, why is it that people who snore the loudest are the first ones to fall asleep? When we talk about the quality of life, 1, chronic irritability, decreased sex drive, memory loss, and daytime fatigue. These are things that matter. Daytime fatigue, men in the room, if you get treated for your sleep apnea, you can no longer blame it, memory loss, on that sleep apnea. You have to choose selective hearing or some other excuse. But the reality is these things are truly impacting our families, truly impacting our cousins, our uncles, our fathers, our brothers, our mothers. If someone's always cranky, I don't recommend that you come up to them and say, hey, you're cranky, you should go do a home sleep study. But you know what, if it works, it works. Get them a test, and who knows, maybe they're frustrated because if you were to wake up 30 times an hour, you'd be frustrated when you woke up too, most of the time. Now, here's a little bit lightheartedness. We got to bring that in because I have a scary voice, I've been told. So we do not recommend taser therapy. That is not shown to treat apnea. It may stop apnea from occurring for a brief moment in time, but it may also cause other things. Laugh and the whole world laughs with you, snore and you sleep alone. Funny, but also heartbreakingly true. 25% of couples in the US are sleeping apart. That's crazy. I know I don't live with my fiance. We're doing things the old-fashioned way, but we will live together when we're married. And I was told that that's one of the perks of getting married, that we get to share a bed. I don't want to sleep on the couch, right? So when we look at this, like that's got to suck. Now I don't have apnea anymore, so I'm not worried about that. But understand that's rough, and we now understand why it's rough because of how loud that sound is, and that's probably why custom-built homes, one of the commonly requested features in a custom-built home today is 2 master bedrooms. Now this person really, really loves their guests. Or they were like, you know, I love you, but you snore like a freight train, and I need a couple walls with insulation and probably some extra soundproofing in your room to split you across from me. Now, I'm just guessing here on the left-hand side. I think there's a secret door in the closet that goes to the garage, so I'm guessing the guy is on the left-hand side, which makes sense. On the right-hand side is the wife. Just guessing, total guess. But when we look at that, this is a real thing. So when we talk to our patients about treating this in our practices, we are really starting to look at what it means to make a difference. We can help couples come together again and sleep in the same bed. We can talk about, you know, increasing their quality of life. We can help them with their tiredness. They don't have to drink 5 cups of coffee to stay awake if they can drink 5 cups of coffee because they're addicted. Very, very different, right? So we're making a difference one step at a time. So going into the next part, the 3-step process. Awesome question, Bakula. We're going to talk about those symptoms specifically next week in our screening webinar. I'll list a few at the question and answer section at the end of the day today. So our 3-step process. Now, this is probably looks really familiar to you. What we've got to do, and we're going to go through each one of them in a very brief manner. But first, where you as a dental clinician play an awesome role. One, we have to identify those who are at risk for sleep apnea. Now, we're identifying those who are at risk. We're not doing the D word, which is diagnosis. And we are going to make sure that we're talking to those patients and getting them to the next step, which is assessment. In most states in the United States of America, all but 3, dentists can own and administer, please understand this word, administer home sleep studies. The interpretation and diagnosis from those home sleep studies must be done by a board-certified sleep physician. Okay? So dentists, you have a unique opportunity because of how frequently you see patients and all this to identify those who are at risk. We can administer the test, but we must have those tests read by a physician, and depending on their severity and based on the physician's recommendations and the patient's, basically their health history, their candidacy for oral appliance therapy, we can then treat those patients based on a couple of those factors. And we'll talk about these 3 in a little bit more detail right now. We'll recap at the end. So let me get through this and then ask your questions on workflow. So when we talk about identifying, first, the big thing on screening, guys, and please, please, please hear me on this, screening should fit in your practice, not break it. Patients are there every day, and you're already asking the questions. Medical history, intraoral signs, chief complaints about the fact that they snore or they're so tired or they're falling asleep in your dental chair. This process should fit in your practice, fit, not break. We need to put it into our workflow, not have it go around our workflow. This is going to start with hygiene, typically in the hygiene chair. We're going to make sure that we're screening patients from the mouth out, and there's a lot of tools that we can use. You have to join us next week to get the deep dive into that because this is a longer training. But we're going to go through what's going on with that patient. We're going to connect with that patient and ask them to do what's clinically appropriate to take home a test. Now, whether you're using a third party or you're using a service in your third party, or you own and operate your own equipment, or if you're in one of those 3 states, maybe you're referring out to a sleep center. Whatever the case, just make sure the patient takes that next step. That is the purpose of screening. You want to figure out what screening form works best for you. We'll go over the Mal and Patty. At the end of the day, you're going to get emailed the Epworth today and our Awaken to Sleep screener. There's a Google Sleep Screener if you really can't find one that you like. There's a ton out there. But find a screener that works best in your practice and incorporate this in. And then we're going to also make sure that we have a patient-centric approach to screening. One, we're going to have less clinical, more relational. Screening from the mouth out and determine the desired outcome. When we talk to patients during the screening conversation, they're being impacted. Something in their life is wrong. They're tired. They don't have energy for their kids. They're getting sick all the time. They don't want to drink 10 cups of coffee and that monster at the end of the day. What is hurting them, and how does figuring out what's going on in their lives help you get to a point where they can stop drinking that 10 cups of coffee, where they can stop drowsy driving? Assess. So we now screen those patients. We're going to get them tested. Again, you can administer tests, a home sleep study, and you can administer your test in a home sleep study, or you can refer out to a lab. But what's the right test? Now, oftentimes we ask the wrong question. We ask the patient, which test would you prefer? And that's not 100% wrong, depending on the part of the conversation it's in. But most patients are going to exhibit the signs of obstruction. We're going to see intraoral signs. We're going to see medical history signs. Those patients who show signs of a neurological condition, those patients need to do a polysomnogram. If your patient woke up in Walmart at 2 a.m. with nothing but a bathrobe and her keys and no memory of how she got there, then that doesn't sound like obstructive sleep apnea. That sounds like she went to bed in her normal bed and had something like REM behavior disorder and drove herself to Walmart because her body didn't stop, her brain didn't shut off her body, so her body lived out the dream. No offense to you guys, unless you really want to treat that, but I'm guessing you don't want to treat that condition. It's a little out of your scope, so I'd recommend that you don't do that. You refer that patient for a polysomnogram. But if they have bruxism or these intraoral signs or these health history concerns, and they're showing signs of an obstruction, then they need to do a home sleep study. The home sleep study, the scope of practice is to diagnose obstructive sleep apnea. That's all it does. Now, it can also evaluate the presence of certain, just the idea of neurological conditions by using the effort. But the reality is you have an opportunity to share with this patient the next clinically appropriate step. Now, here's the consideration for you. If you're not comfortable saying, I want you to do this study because you're showing signs, physical signs of an anatomical response to an obstruction, that's okay. You can refer them to a sleep center. If they're going through medical insurance, a significant amount of the big carriers right now are going to require they do a home sleep study anyways. So just understand that that's the dynamics that things are, because a home sleep study is going to diagnose 90% of the population with obstructive sleep apnea. It's going to rule in the presence of a central condition for that other 10%. A sleep technician can look at that study and say, okay, hold on, something fishy is going on here. This isn't just based on an obstruction. There's something going on here. We need to do further evaluation. Once you get that study done, it's very, 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 very important. I would add another very, but you'd probably reach to the screen and slap me. Do not interpret these results as a dentist. You are a doctor of dentistry. You are specialized in the intraoral cavity and the surrounding, craniofacial structures, okay? That is your specialty. Get a board-certified sleep physician or a medical doctor to diagnose this medical condition. Do not get caught interpreting studies by yourself and then someone come after you for practicing medicine as a dental doctor. You're a doctor, and I don't want to diminish that, but home sleep studies are a medical device that are cleared by the FDA to receive a medical diagnosis. Wherever you are, if you already test, hear me on this, do not get caught unprepared. Please have your studies read. If it's not us, go find someone who can read those studies. They're not that expensive. $79 for an interpretation is way cheaper than the cost of your license. When you get a home sleep study interpreted, please, one big thing, make sure that that study, the interpretation document that typically comes at the top, now these are really, obviously make sure it's recent, physician's recommendation for treatment is clearly outlined. I've seen a bunch that they're like, yeah, here's like 5 general recommendations and you can pick one. Like, I don't like that personally. Please make sure your recommendations are clearly outlined and they have a mild to severe diagnosis if you're going to be using a medical grade device. And very, very important, make sure there's a signature from that physician. If the physician didn't sign the report, then it's not a valid report. That means that some sleep tech probably helped him generate the report and the physician may not have even seen that. So, oh, thank you. I will move the cursor. The physician may not have even seen that report. So please make sure that the physician has signed the report that you're looking at so you guys can move forward with confidence and really be without liability. When you have a physician who's recommending treatment, now you're just providing a durable medical equipment. You're a provider of durable medical equipment. You are managing your specialty, which is the oral cavity and the maintaining the care of a device that the FDA has ruled only you have the opportunity to create. You are the only one who has the credentials to do that. Then, when we know the patient's been diagnosed, we have the recommendation from the physician. The presence and severity of the condition has been assessed. We now understand they're diagnosed, and with this level, then we can move forward in having the conversation about what's available to treat them. So, surgery. If a patient is like me and they want to do surgery, awesome. Maybe they can't do oral appliance therapy, maybe they can't do CPAP, then surgery is a great candidate for them. CPAP is 100% effective if worn. Basically, they say, if I can turn this air pressure up and create this air splint in your throat as much as I need to keep your airway paid, 100% guaranteed. Mandibular advancement or nothing. And that's all encompassed by lifestyle, making sure we're going to bed earlier, we're not drinking alcohol, we're not using substances before bed, certain medications, making sure that we reduce light around our bed space, a whole bunch of stuff. Again, there's a variety of resources out there. I want to talk specifically about oral appliance therapy and your role as a dentist and nothing. So, candidates for oral appliance therapy from a primary treatment standpoint are those mild to moderate patients. You need to evaluate the risk and presence of TMD in those patients. And this is going to work by moving the jaw forward, the mandible. If the maxilla moves, you guys know, send that person to an urgent care or a surgery center because that's a problem. But when the jaw moves forward, the mandible, sorry, I said maxilla, I want to make sure I didn't say the wrong one. When the mandible moves forward, it's going to help move the tongue forward and actually keep the airway open. So that's going to be how we do this. There's dimensions to consider, such as the vertical and the lateral dimensions. But when we look at this, we've seen that the compliance and the effectiveness is considered to be as effective as CPAP in those mild to moderate patients. So mandibular advancement device is kind of the durable medical equipment verbiage. The medical code is E0487. You can look up FDA approval of mandibular advancement devices and you'll see a long list. I mean, there's like a significant amount of appliances out there. Typically refer to them as an oral appliance. When we look at what that means for patients, if you guys want to check out the American Academy of Sleep Medicine's guidelines in 2015, they say that oral appliance can be given as a first line of treatment for those mild to moderate patients. And there are various mechanisms in which that can be done. So the question we pose to you is, do you think that patients are going to be more accepting of a mandibular advancement device or a CPAP? If you had a choice, what would you choose? If you would choose oral appliance or mandibular advancement, go ahead and raise your hand so I can see you. Just make sure you're awake. We're almost done today. I had someone take their hand off. Just kidding. Okay, yeah. We got a significant amount of you that are like, yeah, I would rather do an oral appliance. Now, don't get me wrong. Depending on the type of oral appliance that you're looking at, there's so many different mechanisms. There's so many different tools and little things. And here's the deal. You as a dentist are the one who needs to consider those. Now, these are just two appliances, kind of the classics, if you will, that are appliances that most people are familiar with. But there's so many out there. I've had an OptiSleep and a ProSomnus IA personally. And there's a significant amount of appliances out there. We could do hours of training on just this topic alone. So I just want to show you these videos just to show you kind of how to consider some of those mechanisms that are available there. The last thing I want to talk about is doing nothing. Doing nothing is one thing we want to take off the table for our patients. If they're diagnosed with an airway concern or a sleep disorder, then make sure that nothing is off the table. Plain and simple. We all know what a poorly managed dental patient looks like. That seeing someone that's a poorly managed dental patient is super, super easy. But as my friend Dr. Manning said last week, seeing someone with apnea is not like spotting a toupee. And the result is catastrophic. I just had a friend, and I haven't talked to him in 2 years. He came over 2 or 3 nights ago, Tuesday night, whatever night that was. And we were talking, and he told me that a year or two ago, he slipped into a depression because his cousin died of a car crash. And he told me that he likely fell asleep behind the wheel and ran into the back of a semi. It was not appropriate, so I didn't even mention this at the time, but that sounds like someone who doesn't get enough sleep for one reason or another. There's over 6,000 driving fatalities a year due to drowsy driving. That's what a poorly managed apnea patient looks like, and that's why we're asking you guys to get involved. So, recap real quick. One, we're going to identify those patients. We as dentists are uniquely positioned. We see the patients more frequently than any other healthcare provider. We have the opportunity to observe signs of a physical obstruction and an anatomical response to that physical collapse. And we can administer the test in the assessment portion. We need to make sure that test is read by a physician, and then we can review the interpreted reports, and depending on the severity of the diagnosis, we can help that patient with treatment. So identify, we're going to do it as a dental, we're going to hand off the assessments part to a physician, and we're going to treat those patients when clinically appropriate. So that is my 3-step process in under 20 minutes. I hope you guys got some information that was valuable there. And we just want to let you guys know that this journey begins with a single step today. Now, you may have joined us last week for the Hour with the Expert. If you have not watched that and you're looking for something funny, please go watch that. It was hilarious. Thank you, Dr. Manning and Michael. Like, that was amazing. Super funny, jam-packed with content. Dr. Manning is an expert in sleep medicine, makes over 6 figures a year doing exactly this in just sleep. So go check that out. It's on the Plan Mecca channel. And this is maybe your first step today, and that's awesome. You can't miss next week. And here's why. We're going to go through some of your questions in detail. We have an hour, 1 hour to go through how to screen in your practice. And we're going to give you actionable steps so that you can be screening with patients. And even if you don't own home sleep study equipment, that's okay. Be here. Because you don't have to own sleep study equipment to help patients with airway stuff. We'll get to that next week, but make sure you're here. And to get you back, at the end of this webinar, we're going to be sending you these free documents from Plan Mecca server. And what's going to happen is we're going to give you the Epworth sleepiness scale. It's basically going to say to you, how likely are you to fall asleep during these activities? Now, here's the trick. You do one, and then you give one to your spouse that does one for you. So I would give one to my fiance, Jenna. She's right there. And I'd say, hey, Jenna, how likely am I to fall asleep during these things? You'll be surprised how much more you fall asleep than you thought. Bring those next week. The other thing, there's this Awaken to Sleep screener that has a lot of bonus stuff on there, some of the intraoral signs, medical history, stuff like that. Specifically on that screener, the bottom portion is a questionnaire. It's a yes or no section. If the answer is yes for any reason, the answer is yes. I want you to add up your score. The score is the number next to the yes or no. If it's yes, you don't get 1 point, you get the score next to it. Add up your score, bring your score next week, because I'm going to ask for that next week when you see me. And we're going to figure out who has a high score for bragging rights. Again, you 9 from earlier, you get to brag about today, and probably the 5 or 10 people who tie next week are going to also get to brag then. I was a 39. Michael Cohen was a 42. Let's see if you guys can beat us. So with that, I want to open up for question and answers, and I'm exactly at 1 hour. So we got a couple questions here.
Real quick, before you dive into questions, I just want to let everybody know that I am posting the CE survey link right now in the chat function. And just a reminder that we will be sending a follow-up email that will include those documents that Chad just referenced, along with the CE survey link in case you don't want to do that now, and a link to the recording of today's webinar. So with that said, I'll hand it back to Chad for Q&A.
Awesome. Thank you so much, Jody. Yeah, if you guys need to get out of here, go ahead. We totally understand. We have some good questions, though. So starting with the first one we got earlier, what are the symptoms of sleep apnea on a daily basis, those we can evaluate besides snoring, so we can make a decision to do a sleep test? We're going to talk a lot more detail about this next week, but some of the intraoral signs that you can observe. So one, we've got bruxism. We've got, oh my gosh, now I'm blanking because that's not the mode I prepared for today. So we've got bruxism. We've got impressions on the tongue. We've got enlarged tongue, macroglossia. We can actually see that just by looking at the malum patty. We can also see that patients who are talking about tiredness or falling asleep, we can look at the medical history, any of the things we talked about earlier today. Some of the daily complaints, you're going to hear tiredness, drowsy driving, fatigue, snoring, stuff like that. And once you start learning and listening to these things, you're going to start to know more. But that's my short answer for an hour-long training we'll be doing next week. So thank you so much. I'm Bakula. I appreciate your question. Can we please comment on pediatric patients' diagnosis and treatment? Yes, great question, Dr. Shah. So pediatrics are an entirely another topic, an amazing topic, and one that we have an extremely large passion for. And the reality is that for pediatrics, we can screen them with some of these intraoral signs and symptoms. There's some differences, and we'll talk a little bit about that. We are focusing on adults, but there's amazing programs out there for much more deeper dive in education. But we can see a lot of the intraoral signs that we'll discuss next week in kids. We can also see acid reflux can cause apnea in children. There is only one sleep study I know of on the marketplace that can diagnose children. That's called the NOx-T3 unit. In addition to that, you can also do an in-lab study to diagnose a child. When you guys are finding children who need help with these airway concerns, though, you need to have a multidisciplinary approach. You need to involve a pediatric doctor and a pediatric ENT, because there are things you can do as a dentist, such as growing out the anatomy to allow for a proper airway and development, which can be done by guided orthodontics. There's also surgeries that can be done, and other considerations such as vitamin deficiencies. So you can contact us privately. We've got a huge heart for that. We're happy to talk to you guys. Plan Mecca has some links to talk to our team, so we can go into more detail with that. But as relates to this presentation, you want to kind of limit that scope. But here, just understand, when you start talking about kids, make sure that you, one, are familiar with orthodontics and you're working with their other healthcare providers, pediatric doctors and pediatric ENTs, and make sure to get them diagnosed. Don't start treating them for airway unless they're diagnosed again. We want to make sure that we're doing the right thing by our patients. Patients first, always. What if the patient is complaining of jaw pain after wearing a mandibular advancement device? Yeah, so great question. Now, there's a more complicated answer, and it depends on the type of jaw pain. So those specifics we can kind of get into later. But basically, as it relates to jaw pain, if you were to go to a movie, or maybe you're sitting on your couch and you were to put your legs kind of over each other like this, right? So, and I can't demonstrate for you, unfortunately, but if you were to cross your legs on your couch and you were to fall asleep and you were to wake up after an hour or two, would your leg feel good? Likely not, unless you've got legs of steel, in which case, congratulations. But the reality is our leg was sitting in an uncomfortable position and for hours, and so it's going to kind of hurt a little bit, be sensitive, and we're going to have to kind of walk around, but we never like think about cutting off our leg, right? Now, Dr. Manning is the one who I definitely stole that analogy from. But here, when we look at this, when our jaw is being held in a forward position for 6-8 hours, sometimes only 4 when they're getting started, that's going to create some soreness in our muscles. That makes sense. We're stretching our muscles out. So if they're just starting with treatment, they need to give it some more time. And help the patient understand, set expectations. This is going to be uncomfortable. There's going to be some soreness. We're going to see that it's going to happen. One, you can do jaw exercises, stretching the jaw. I used to chew gum with my oral appliance. It helps reactivate the muscles so that I gain my bite back. You can do morning repositioners. You can massage the jaw as well. So that's not a contraindicator for sleep appliance. It's actually an expected side effect at first. Long term, that patient won't even wake up in the morning knowing that the appliance is in their mouth. At least I didn't. So that's one side of it. Now, there could be the other side of the type of jaw pain that could be a contraindicator for that patient, in which case, not time for today, but that is a topic that you should explore in more detail. And there's other courses. We offer some of them that can go into more detail specifically about that. You just want to look at the type of jaw pain and what's causing it, if it's something that's part of the getting used to process, or if it's really something that we need to adjust the appliance to consider for, or even potentially stop using the appliance. Those are potential options. But most of my friends who do this and do a significant amount of cases say it's less than 10% of their patients that have issues long term. What are your thoughts on orofacial myofunctional therapy? I think it's fantastic. I think it's an amazing way to increase effectiveness of therapy. I think that it is a way to increase the effectiveness of oral appliance therapy while also helping patients who are not candidates for oral appliance therapy. It's going to help longer lasting efficacy, because the reality is that there are a number of studies that have shown that certain patients over time are going to have this therapy be less effective. So that just being said, myofunctional therapy can help condition the body to be more effective long term. So Natalie, to your question, myofunctional therapy is extremely valuable, and it is, again, sleep is something that you can get started with in an hour, and tomorrow we'll show you how to make money in another hour, so 2 hours. But the reality of the education and the levels of implementation are almost endless. So great question, thank you. I have a CPAP and oral appliance therapy, and I brux. I alternate due to TMD, and any recommendation with oral appliance, I have had my dentist adjust it. Yeah, so your TMD is a consideration there. Sounds like you got a pretty good system going on there. You could potentially wear an oral appliance with reduced pressure on the CPAP, and you could also make sure that you have a oral appliance that's rated for bruxism. If you are treating the sleep apnea completely, then I would just make sure that you're having bruxism while your apnea is treated, because oftentimes we see that apnea is primary and bruxism is secondary. So if you wear both at the same time, then that could potentially reduce that, so you wouldn't have to have a dual-rated appliance. But dual-rated appliance and combo therapy would be a good option as well. Yeah, myofunctional therapy may also help with your TMD as well. So great question. I think I got to all of them.
I think so.
Thank you, Margaret. Yeah, any other questions? Sorry, Jody, go ahead.
No, it's all good. I think we got them all. There were only a couple questions about the CE survey, so I think we're in good shape. Please join us again for next week for the third in our series with the guys from Awaken to Sleep. So if you need the link, I will actually put that in the chat function real quick. But it's the same place where you registered for this. So info.planmeccausa.com/webinar. And you can find the registration link there. All right, thank you so much.
Awesome, thank you guys so much for participating. You're a great audience, and glad to see that you guys definitely showed up today. See you next week.
Sounds good. Have a good weekend, everybody.